So I'm teaching them about Gladys Knight and the Pips. And Crystal has been asking for me to sing.
Yeah, you have.
Yes. So Joel has a CD of me singing on it. So there's an old-time smoker, what we guys used to do in the old days, you know. So I'm on it. He doesn't have a burner. Anybody of you guys have a burner? CD burner. All right, you probably have to put it online so you can see what the old-time smoker is. I'm not sure Gardner gets a copy or something. All right? So you can relax at length and you need some leisurely entertainment. Okay, today's thing is on the female reproductive system problem, right? We're going to begin with the ovaries, right? We begin with the ovaries, female gonads. I just briefly the embryology. Start there from the top, below you. Stand where you call that color? Orange. Embryology of the ovaries, brief. The development of the ovary. I know what part it develops from man. That's what the embryology is about, don't you? Dr. Thomas did it more brilliantly than I did, I mentioned. No, you can't say anything more than right. You have a thing called the intermediate mesoderm. Remember that mesoderm differentiated into three, no sir?
Yes.
Most medial is it? You must forget these things in there if you carry these things. Like the paraxial mesoderm, right?
Yeah.
And next to that would be the intermediate. And then laterally mesoderm. So the gonads in everybody develop basically from the intermediate mesoderm. So they get proliferation. You see them epithelium there. And at early stage of development, in both sexes, we have an indifferentiated gonad being formed. It can either develop into the female or the male gonads. You understand? But we're dealing with the female ones. No? Okay. Mr. Gardner showed you on the histology just last week. In the guys, he showed you spermatogonia. What are they against spermatogonia? A and B. And then after the A and B, you must get a C. And what is the C in the development called? Sorry? Right. That's all right, Sharky?
Right.
Spermatocytes. So you see, it's not too hard to remember. EEC. Spermatocytes. And the C's will develop following with a D, that's all? So what is the D? Spermatids, that's all?
Yeah.
And then we'll end up down by this. Ultimately, the spermatoid. So after you have spermia what? It tends to the zoo. What do you call that process? Spermiogenesis, right? So we're not dealing with the male, we're dealing with the female. Because in the males, the spermatogonia will multiply and multiply to produce 3 million of sperm at ejaculation. So we guys have to be constantly producing, manufacturing new spermatocytes. And that's why we guys have to eat so much and rest so much.
Rest a lot.
Rest a lot, yes.
You still hear that? You have to rest a lot.
And we need a cool temperature to sleep with rest. You don't need to write this, man. You all know this.
Write that down here, Crystal. You may need to rest a lot.
Okay, you girls now. You don't go through that whole process of multiplication to produce 3 million each time. You're born with what you're gonna end up
Yeah.
having for the rest of your life. Huh? So when you ladies know, where are these gametes coming from?
They call them germ cells.
Yeah, with germ cells. Follow me? You are the differentiated gonad being formed. So where are the
was on
gametes?
vacation, she's come back, right?
Yes.
No, she was on vacation. No, down on the North Coast for 2 weeks. Right, yeah, continue, bro.
So where are the gametes coming from in the female?
Right.
Miss Jamaica says the yolk sac. Is that true? Yes, man, that is weird. They migrate from the yolk sac to reach the differentiated gonad in the female. And what reaches there is that what you will have forever. So they said theoretically you're born about 500,000 in October or so. But you see, a lot of it goes to is because says that senior men after 10, that's why he's 10, and you end at 50, that's 40 years now. So 40 years, time each month has 12, right? That's what, 480, that's all they need, yeah? So we guys have to keep working because you're born with that finite number.
And then relax.
So the ovaries now. Oh, is this you having trouble? You bring me here today, not here today. Okay, this is the pelvis side view. And this thing here, that's the ovary, eh? And overlying it should be the tube, eh?
So this was from a lady who had donated her body to medicine.
And this specimen, here now.
Just push that one away, Patrick.
This one now shows ovaries, eh? You can recognize the fundus of the uterus there.
Yes.
And these structures here are the two ovaries, eh?
So just to orientate yourself, are you looking at the anterior aspect of the uterus there or the posterior? That's the posterior surface.
Daniel, what stretch aspect you looking at?
Just to orientate yourself.
I told you anytime you can see the ovaries, it's the posterior aspect. So that's the posterior aspect, eh? So you see ovaries, eh? And some say the dimensions 1, 2, 3 centimeters is the rough figures. 1 centimeter thick, 2 centimeter wide, and 3 centimeters in its longitudinal length. These are a little small in chunky. These are a little small.
No, this is a lady who was killed by gunshot when she was about 35 years old.
I think so. Just kept on blocking.
That's on that specimen, this is the ovaries.
Body came up here.
On in this cadaver
That's how she
specimen,
died.
this probably Steve Roy exam. And the cadavers, you know, are usually, with few exceptions, are usually old people. Yeah? We tend to die when we are old, like me, so. And they become atrophic, eh? And this is the atrophic ovary in this instance, all right? Yes, this nominal thing. It's atrophic. Doesn't look as nice as in that one, eh? Okay, so you appreciate that?
Yeah.
So, we know the embryology of the ovaries, and they will descend and end ultimately in what position? Where you find the ovaries? Yes, you.
More like posterior?
In the posterior lateral aspect of the pelvis. But it lies in a specialized area, the so-called ovarian fossa of Claudius. So tell your colleagues the position, the boundary,
The ovarian fossa.
the ovarian fossa. So, but don't be shy, you know, all of you in your hospital, you're gonna have to talk.
Mm-hmm.
You have to talk to patients, you have to talk to your consultants and your seniors,
Yes, Jesus.
because they have patients to present. So
And the
don't be shy.
relations of the ovary are very important. You're going to see a lot of people now females coming with ovarian problems. And their ovarian problems will manifest themselves in what the ovary is related to.
Yeah.
So, madam, just remind us quickly of the boundary. That's a little last slide. The ovarian fossa.
Excuse me.
External iliac,
Artery, that's one, yes.
urethra,
Yeah, so that's
and
it.
internal iliac.
Anterior superiorly is the external iliac, posteriorly, inferiorly, the urethra, and the anterior
Of the obtuse.
division of the internal iliac artery. So it's just in that little V-shaped area that you find the ovaries are. All right? Now, in the specimen which we had showed you on this one here, keep bobbing and weaving between the different specimens. This one here, Brittany.
You use that.
Yeah.
Yeah, man, go ahead. You want the punch?
Yeah. This is the ovaries, right?
You can pick it up.
And we are posteriorly placed, right? Because
You can pick it up with your hand if you want.
yeah, sorry. Extending from the posterior and anterior surfaces of the uterus, extending lateral to the side wall of the pelvis, is this structure, this broad structure, eh? Right? So you see that ligament?
Zoom down a little bit more. Good, excellent. Beautiful.
You see the broad ligament of the uterus, yeah? So it covers the posterior and anterior aspect, yeah?
And you see the name is very applicable, right? Broad. Just hits
Yeah,
it.
very true.
Like a sheet.
Now, at the superior lateral angle, so-called cornea of the uterus at this point there, is where you'll have the attachment of the uterine tube. We're going to deal with everything. Yes? And you can see it is line within the broad ligament, uterine tube, and the peritoneum covers from the front and superior aspect of the uterine tube. So you have a fold of peritoneum from the broad ligament to the uterine tube. And this aspect of the broad ligament is called the mesosalpinx. You see that? Mesosalpinx is tube. And anything with a mesentery-like structure, peritoneum is meso. Small bowel mesentery, sigmoid, colon mesentery, that sort of thing, yeah? So that's not hard. Now, the ovaries are posteriorly placed, and extending from the posterior leaflet of the mesosalpinx is a fold of peritoneum. You see it?
Yes.
Going that way to the ovary.
Yes.
Yes. And similarly, inferiorly.
Yeah, yeah, that's the way you picked it up. You said
Yeah,
right
I see
there.
that.
There.
So you will see this aspect. So the ovaries now,
So that one is going to be mesovarium.
right, has this fold of mesentery called the mesovarium. Yeah? Now, just looking on the ovary as is, yes?
Yes.
It has the appearance that this area of the ovary is continuous with, I'm saying just looking on, it has the appearance of the peritoneum, the mesovarium, got it?
Right.
So madam, with the chin, yes, touch out the formula. I don't know your names, you know, yes, you. Is this true, that the covering of the ovary here is the same as the peritoneum there? Sorry? You give me an indefinite answer, you know. You say somewhat, no?
Yeah.
It's like I'm asking if you love me.
Somewhat.
And you love me. So.
Somewhat. Well, at least it has a little hope in it.
I see some little hope, but at the same time, there's no hope.
She didn't say no.
So what you say? You have to give me a yes or no answer now. Huh? You say yes? Gotri agreed with her? You don't what you said then?
I said they're not continuous.
Huh?
They're not continuous.
No, it is not continuous. Where the mesovarium peritoneal lining reaches the ovary, it stops there. Yeah? So what you see covering the ovary there is not peritoneum. You understand? So my beautiful lady in the blue, is this all that color? Still all colors? No? Which is it? Pardon? High school. Oh yes, tomorrow champ starting. What school is that? Sorry? Campion. You're not doing too bad, you know. First time when you talk about champs, you never mention the word champion.
Not really keep the sport.
Not in it.
No, not in sport.
Yeah. But this year in the World Indoor Championship, can you imagine a champion guy, you know of him? Who wins a silver medal in the triple jump. In the triple jump of all schools. Champion. So, what covers the ovary now, as I'm showing you there? Give Miss Campion a chance. We said we know it's not pertinent. It looks like, but it's not. Mr. Chuck, help her out.
I believe the peritoneum were separated by a white line of sorts, and the peritoneum has flattened mesothelium, and the ovary, I think, has simple cuboidal layer or terminal.
Right. So the covering of the ovary itself is not by peritoneum, but is of cuboidal. And the cuboidal epithelium is erroneously called the germinal epithelium, yeah? Because in the old time days when they didn't really appreciate all of the things that we now know, they thought that it was these, like in the
Testis.
tubules of the testis that you'll have a spermatogonia, that these would give rise to the eggs, basically, yeah? But we know it's a misnomer. But the terminology, germinal epithelium, still continues with us, eh? Right? And Mr. Chuck mentioned a line which I mentioned to you, where the peritoneum meets the cuboidal epithelium. There's supposed to be a white line, which I can't really show you as such. This is called the white line of Waldea. Crystal is the Waldea girl. She knows a lot about Waldea.
Who is that, Melissa?
Yeah, no, man, Crystal.
Crystal.
Remember, she knows a lot about Waldea.
She has a boyfriend by that name too.
Okay, so
Crystal.
you need to understand that, right? So you have the white line. And it's at this area where the blood vessels and nerves to the ovaries are coming in. So that mesovarium border there, right? Is often referred to as the hilum, where the vessels enter into the ovaries, right? We're not going to go much into the structure of the ovary itself, because apart from its germinal epithelial layer, cuboidal, deep to that is what other layer? Like young lady, you're picking out the girls, yes. You don't want to look at me, yes. What immediately lies beneath the germinal epithelium of the ovary? Huh? No, what about that lady with a nice, it's a pinkish color, maroon. Touch her for me now. Yes, you. What is immediately beneath the germinal epithelium of the ovary? Pardon? You better think about yourself, man. Nobody? Right. The testicle on the outside has a thick white coating, the tunica albuginea. So everything gonna start as one, you know. So you'll expect to find a tunica albuginea here, yeah? So you do have a tunica albuginea. Yeah? And the eggs, when they're gonna be released, they fight and have to fight through the tunica albuginea, then through the germinal epithelium before they are released. Yeah? So a lot of effort there, you know? Good. Now, as you can see, the ovary, they tend to lie slightly obliquely, longitudinal, like the testicles. It's like more or less obliquely, right? And longitudinal in the ovarian fossa. And we see the tube is there, right?
Sure.
The uterine tube is closely applied to the anterior lateral aspect of the ovary there, right? And at the end of the tube, which we're going to go into in a little bit more detail, you can see the tube is narrow, this part, and it gradually widens us. And it's approached like that. Because the parts of the uterine tube, which is roughly 10 centimeters, there's a part that passes through the muscular coat of the uterus into the uterine cavity. That's called the mural part. Yes. And next to that is this portion, which is also narrowed down, you can see that, and it's called the about 3 centimeters, 1 centimeter, 3 centimeters, and it's about 5 centimeters or so. And this part is dilated, as you can see, and it's called the and from the ampulla, like a trumpet, the distal part is widened like the trumpet, you know the trumpet? I want to call that widened area, if anything, like a trumpet. Infundibulum, right? And from the infundibulum, you have a number of finger-like processes, almost like villi of mucosa, right? That passes through the infundibulum towards the ovary. And these are called the fimbria. Is that right? No?
I'm not just looking at you.
Okay. And one of these is particularly long, and is that in fact attached to the ovary. Right, sir, in the maroon shirt over there. What do you call this one? You with me? You're over there. Yes. It has one number of finger-like processes called the fimbria. But just like the middle finger is the longer than the others, in the ovary, you have one longer than the others. One fimbria that's longer than the others. Eh? Now what do you call this one? The longest one? The young lady beside you, to your left. A nice pink blouse, yes? You don't know either? Melissa.
Hi, fimbria ovaris.
Right. The ovarian fimbria or the fimbria ovarica. And it has a roll in. The lady in the pink, you don't know what a roll it is in you. It is said to pick up in brackets and guide the released ovary to the tube. You understand me? So it has an important role. When that egg is released, the ovarian fimbria sort of guide and pick it up to reach to the tube. And while we're talking about the peritoneum, in you girls, the lady in pink still, is your peritoneal cavity theoretically in communication with the exterior, the outside world of the body? The lady in pink. You understand the question? Huh? She answered? What you said? Oh, I'm asking your peritoneal cavity, is it in communication with the outside world?
No.
Because Joel says no. You agree with Joel?
A vagina.
That's peritoneum.
What you say? You agree with him, yes or no?
Ask
You agree with
Crystal.
him?
Ask Crystal. For me.
Crystal do agree.
Crystal, is it in communication, yes or no? Is the peritoneal cavity in communication with the outside world in the female, yes or no?
Yes.
Yeah.
Yes, it is. You have to remember that, you know?
What's this?
Because the vagina is open to the outside world, not it?
Yeah.
And the cervix that has a canal which is theoretical open to the external world.
Cervical canal.
Right, and the uterine canal is again patent, and then the uterine tubes. So you can see where it is in communication with the outside world, huh?
Yeah.
Whereas we guys, ours is closed off. There's no communication with the outside world. And they're found in little girls, you know, sometimes they get infection down there without any sign or knowledge of any sexual encounters, eh? And they are postulating that's because of that communication whereby the bacteria from outside can get up into the tubes and cause problem down there, yes sir? So you need to know that. Now if you look closely here towards the uterus, below the tube, you see there's a structure here attached to this portion of the ovary. You see?
Yeah, clear.
Clear. Good. That lady in the maroon, touch her, yeah. What you call this thing? Right, you heard that?
Yes.
It's the ovarian ligament.
Yes, sir.
And it connects this pool, which is therefore called the ligament, what they call it, ligamentous pool?
Yeah.
Pool. Yeah, where the round ligament, sorry, not round ligament, ligament of the ovary is attached. Eh?
You can actually look at the screen, you can see the round ligament continuing on. Look how you had it tilted. Look at the screen. See the going to it and then look coming down below it now, the round ligament.
Oh.
See there right there. See right
So
there, that's it right there.
And this ligament of the ovarian ligament, is in continuity with something which Mr. Gardner is saying there.
Yeah.
And I'm trying to see if I can see it here. Here it is. It is in continuity. I don't know if you can see that three-dimensionally. Hold the tube out of the way. This here that I'm holding is a round ligament. And this here that I'm holding is the ovarian ligament. Yeah?
Can you show us again?
Okay. Remember the round ligament is going anteriorly, so it always is anteriorly in the broad ligament. Then. So you all appreciate that? The ligament of the ovary is in continuity with this round ligament of the ovary. You understand that? And that gentleman with the stroking his chin there.
Ask Joel what this is represented in the
I
male
was
by.
gonna-
No, Patrick, I want to ask the Joel. Joel, in the male, what is this represented by? The ovarian ligament and the round ligament are really one structure, continuous.
It's
In
like
the
a
male,
nice examiner than me.
Lord have mercy. In the
So
male,
it's a-
no.
it's a new
In the
tremendous.
male, represented by what? You
They
have
are
any idea?
derivatives of what?
It had, if you remember inguinal canal, it will be a hint. Right. The
Correct.
gubernaculum testis.
The round ligament and ligament of the ovary are in continuity, yeah?
Like in the name.
Like in the male. And are represented developmentally from the gubernaculum.
Yes.
Yeah? So in our guys, the gubernaculum guides the testicle down into the scrotum. But in the female, in the indifferentiated developing infant or baby, in utero, fetus, it's attempting to guide what could have been a testicle down. Eh? And in truth and in fact, sometimes the ovary don't end up where it should be. Sometimes you find it in the inguinal canal and even going down into the labia males, which is corresponding to the scrotum. You understand?
Yes.
And once you find an undescended testicle or mal-descended testicle, And once you find a mal-distended ovary now, yeah, there's always something that is there with that. Yeah, that lady in the white blouse, touch her from in front of you. What is always a undescended, mal-descended testicle or a mal-descended ovary? There's always something in the inguinal canal. And if you understood the descent of the testicle, then you'll understand. Preceding the descent of the testicle, there's a gubernaculum. In the old time days when I was a student, they said it had tail to fibromuscular tail that would drag the testicle
pull it down.
But we know that is no more so. It's just as a guide, you know? But something else guide the testicle into the scrotum. What is it? Sorry? What is that? Help me now. I don't remember my old man. Suspensory ligament? No, man. You, my orange blouse. Huh? Tell them Dania. Then you name this.
Is it the canal?
The processus vaginalis guides these gonads down to where it wants, it should be going. You understand? So once you see this, the person, that patient, always have an unclosed processus. And with that, depending on whether this is the patient, they all have a patent processus. And it could give rise to what is called a communicating hydrocele or a hernia. You follow? You understand dreamy eyes? You sure you do? So in you know, in a lady that should have a mal-descended testicle, sorry. The persistence of this processes cannot. What terminology is given to this patent processes in the ladies?
Yes.
Yes, ma'am. It's very near to the F word, you know?
Anyway,
Canal of
let
no.
us move on. Let us.
They'll remember that now that I mentioned that, you know? You all remember the wrong thing.
No.
The canal of Nook, eh?
Came in the last two practical exams.
Excuse me?
Came in the last two, and therefore, good probability of returning. Canal of Nook, very important. So Patrick, would you say there's an ectopic over there?
Yes.
You could
yes,
classify it
yes,
as an
ectopic.
ectopic over.
But the canal of Nook is an ectopic.
So the ovary may be in the inguinal canal
Right.
or situated in the labia majora.
Yeah, that makes sense.
You understand that?
You use that term with them, Patrick. You can explain it to them. You said a communicating hydrocele.
Yes.
Because maybe they don't know that term.
You understand?
Communicate. What? Ask Melissa if she knows. What is a
I'm
communicating?
gonna pass this one to Dominique.
Is it? You can tell them, Patrick. Use the term.
Okay. You know, there's always a little fluid within the peritoneal cavity, don't it?
Right.
For lubrication purposes, for the gut, etc., to move around, eh? Now, the processes is a continuation, a diverticulum, as it were, or portion of the peritoneal cavity, no? Yes? So, some fluid should be there, yeah? So, with time, whatever fluid there is in the peritoneal cavity, the fluid will, with the gravity when you stand, will go to the most dependent part. That's in the processes now, you understand? And that's a hydrocele. And the cough, you see, gets bigger when you check it, it's cystic, right? Fluid in it. When you lie down, the fluid will reduce into the peritoneal cavity and it disappears. Okay? So it communicates. The more common scenario in the elderly men is that there's no communication. It's just of the peritoneum processes that persisted around the scrotum for lubrication. Yeah? And that is often referred to as the vaginal hydrocele. But we'll come to that tomorrow. Yeah. So you understand the gubernaculum that plays a role there. Now, the specimen I'm trying to see now, I'm trying to see, but I don't think I'm seeing it much luck.
What are you looking for, Nick?
The ovaries at the opposite end. You have the tubes, and the other see the tube, so that the other end is the tubal pole of the ovary. Yes? But another important structure that helps to suspend the ovary in its position, right, is the suspensory ligament of the ovary. And these specimens have been badly traumatized. That it is rather difficult. This is a round ligament. Here. This is the ovary. So not round ligament. Part of the tube coming around the ovary. All right, let's try to decipher this. So you see the broad ligament, yeah, with the ovary, and this is the uterine tube with its dilated terminal portion. Yeah. So if you look down, you can see what I'm holding in my left hand. This here. You can see a fold of peritoneum with some structures running down towards the ovary. Yeah? You see this? You see this atrophic ovary? Sorry. I need the extra hand here. Okay. So this is the tube, the upper part of the broad ligament. These are salpinx. This is the atrophic ovary. Yeah. And this portion that I've pinned up here is the continuation of the tube. Yeah? To the infundibulum. And this structure going to the ovary with some darker structures in it, which one of the vessels. You know what this is? Right. This is called the suspensory ligament of the ovary. You have another name which the clinicians more usually use. Right. The infundibular pelvic ligament sounds a little bit more high class to suspensory ligament. Yeah. So they say infundibular pelvic ligament. Yeah. And what it is, there's a fold of peritoneum. Yes, in which vessel, which we have shown you, not in these specimens, but in other lab specimens. What is running in this ligament? The ovarian artery, which is coming from the abdominal aorta. Yeah? And what else is running up in this infundibular pelvic ligament? Veins, the so-called pampiniform plexus. Just like in the testis, yeah, the pampiniform plexus. Initially, there's a pampiniform plexus in relation to the ovary, but ultimately they join up to usually form one, sometimes two, but usually one gonadal vein, ovarian vein. And on the left-hand side, I can't show you because we don't have all of that. On the left side, no, that lady in pink. On the left side of our body, your lady's body, your left ovarian vein will drain into what structure? You with me? The vessels, the ovaries receive blood by the ovarian artery, yes? And must have blood returning, now we come in. Ovarian vein through the pampiniform plexus. On your left side, you know, where does the left ovarian vein drain to? Huh? You have to take this thing seriously, you know. Your mom and dad work hard to send you here.
Left renal.
No, you're not. What about the guy beside you?
She said left brain only.
She said it. You have to talk a little louder, you know, remember? Looking a bit otosclerotic. Hard of hearing. Okay, so on the left side it drains into the left ovarian vein. She said, then what happened on the right hand side? The same young lady. I want her to pass and enjoy herself just like the rest of you. Come this way, when it's the exam.
Patrick, you don't mind, I'm just digressing for while you're thinking. Can I help? You must see this. You know, we're talking and listen to Dr. Lodenquai. And this is why we come to the gross anatomy lab. Look how massive this femoral ring is. You see the size of that femoral ring? Look at it. See there? That's massive. So this is really begging for a femoral hernia. Yeah. So the female pelvis is wider, and I'm amazed. Look at the size of that. So look, see the anatomy right there, and then see the vessels right there, and then beautiful, and that's Dr. Lodenquai pointing out. That's the deep inguinal ring, and right there, that's a beautiful round ligament of the uterus. Hey, Patrick? I mean, this is a fantastic specimen. What shocked me though is the size of the what? The femoral ring. The femoral ring crystal is an entrance into what?
This is wrong.
You got it here? You're right here, yes, right here, yes. So you see there? So that femoral, that ring, is the entrance going into what? Into the femoral canal. That's all? All right. What's the length of the femoral canal?
Area. 1.25.
No, quite a bit longer than that. Femoral sheath, right. So I just have one point. But that's how you, yeah, there's a round ligament right there. So the deep ring is right about there. Okay, but I had to point it out to you. See right there, you should take a picture of it. Massive, look at that. See there, look how big that is.
Why going up so far?
Sorry, Patrick.
That's all right.
It's just I saw it and I had to. Yeah, it was so beautiful. Femoral what? Females tend to get what kind of hernias? But what's the most common hernia in the females? Correct, umbilical. Sorry, Patrick.
Okay, so you understand? The left gonadal, where the ovarian or testicular vein, on the left hand side, drain into the left renal vein. But on the right side, it drains into the, commonly into the IVC. Very rarely into the right renal vein. I probably even should mention, but it's very rarely. Commonly into the IVC, yeah?
From here, okay.
Yeah, right.
Okay, the ovary, you're talking about the blood supply. The arterial supply is dual, two. One we mentioned earlier, the ovarian artery. And the second one is the uterine artery. Yes, I did show you some uterine artery in the past. I'm not sure if I will see it very easily. You have to look hard for it. We can find it because this structure is the, you see that structure? Coming all the way from the kidney. The kidney. This is the ureter.
Okay. So you must be anterior.
Yeah. And down here,
Excuse me. Why am I so congested?
the formalin on this thing, you know?
Yes,
That's why I couldn't see.
strong.
The formalin gave me eyes and it was a hard time. So, passing over the ureter is this structure here, coming from the anterior division of the internal iliac artery. You see?
Yes, I can.
That's the uterine artery, yeah?
Right.
The bridge over the troubled waters. Eh?
Yes.
So that's nice and easy. two arteries, uterine and ovarian. You want to show them that shortly?
Division of the
It's like a-
You can zoom right down here, Brittany, right here, no? Right there, right in here. So you can see it here. That's the uterine artery, right? And there we can see the ureter. And you can see the crossing. See the crossing? All right? But what I want to show you, very interesting, Dr. Lodenquai talk, if we look on the other side, look on the other side. So if you look on the other side, you see what the surgeon is going to encounter when he gets into there.
Yeah.
Look at the amount of vessels.
Yeah.
You see the amount of vessels there? It's just full of vessels. So that's why sometimes he gets into a problem with this, with the ureter. See here, right here? Right, and then look at the leash of vessels all surrounding it there. All right. All right. You can see
Right.
it. And he has to go down here. So, and then sadly sometimes, Crystal, what happens? Look, sadly sometimes, yeah, damages ureter, yeah.
Right. So you understand that that's full of peritoneum that's carrying down the ovarian vessels. It begins on the right side behind the cecum and the appendix and terminal ileum, that's full of peritoneum in which the vessels are running. Yeah. Whereas on the left hand side, this begins, the full peritoneum begins where the descending colon continues into the sigmoid. Yeah? And why I mentioned that is that the ovaries, sometimes when they're taking them out, or removing the ovaries with forectomy, they have to ligate these ovarian vessels. And they tend to ligate it, usually at the pelvic rim. And right at that point, you'll have the ureter crossing over the common ileum bifurcation. We showed you that, right? And just immediately lateral to that is where you'll find the gonadal artery and vessels. Huh?
Yeah.
So you can see where, if the guy is not careful, he picks up everything and attempt to ligate the ovarian vessels. Ligating the vessels, which he wants to do, but in addition, can theoretically ligate the ureter. So that's the significance of that situation. Huh? So the lymphatic drainage now, we're going to follow the arterial. Yes, I mentioned the term infundibulum pelvic, which is what you hear when you get into the hospital, more than suspension. The ovaries now, the lymphatic drainage is to the regional lymph nodes. So the aorta gives off the ovarian artery, so you'll get para-aortic or aortocaval nodes right here. Yes? They can travel down by the uterine artery to the pelvic group nodes, internal ileum, etc. You follow that?
Yes.
I think I've been talking enough about the ovary now. When tumors and so cysts, etc. of the ovary develop, you can see where the ovary will get bigger and bigger, don't it? And with time, it will drag the mesovarium to form a longer mesentery. You can appreciate that?
Yes.
Right. I was just going to say like a more boxed-up lady, as the breast gets bigger, she needs a bigger bra, you know? So similar what's happening to the mesovarium, you know? And one of the consequences of that,
Just be careful.
one of the consequences of that is that the ovary can undergo torsion, severe pain, as you can well imagine. Whereas in this normal situation, it's difficult to see how this will tort. You understand? So I just mentioned torsion.
So my daughter, who is a radiologist, the number of times she will see torsion of the, she has like very rarely will see torsion of the testis, but far more common torsion of the ovary, because the ovary has that mesovarium and it can twist around on itself. Right? So you'll see torsion of the ovary.
Now, what is important is I come this afternoon for histology of the female system, because the ovary is always in the exam.
Oh,
And you have to be able to identify primordial, secondary, mature follicles. You don't know which one the guy is setting. You understand? So make sure you come and understand. I'm not going to go into that. Mr. Gardner with the picture this afternoon. The uterine tubes now. Embryology again.
here.
Madam, where does it develop from? Straight ahead. Yes, you. I don't know your names, you know. And you don't know your name.
Crystal
tags.
knows her name.
A lot of them don't know each other yet. Names. What does the uterine tube develop from? I'm not hearing it too well. What you says? All right, but more specifically, what structure that mesoderm does it develop from? Right, the paramesonephric duct. Yeah? And we said the tube here, roughly 10 centimeters long, plus or minus. And it has 4 parts. We mentioned the mural, which is the narrowest luminal part, 1 centimeter long. Then the isthmus, which is narrow, but the diameter of the mural portion, about 3 centimeters long. And the ampullar portion, which is about 5 centimeters. These are approximate lengths. And it has the dilated portion, the ampulla, the trumpet, the ampulla, and I mentioned the fimbrial folds. And ovarian fimbricle, okay? And we said this closely applied, the tube is to the ovary. Now, the arterial supply of the uterine tube is campion. You know, any other campionites with you? Dreamy? Dreamizers?
Campion.
Not talking present yet, campionites. Present day. The uterine tubes develop from the arterial supply. The blood supply of the uterine tube, fallopian tube, uterine tube. Just like the ovary, it has dual supply, ovarian and uterine branch. And the veins will follow suit. Who else? This is a campionite. Apart from, no, I have asked. Sorry?
I went to Jamaica College.
He looks more like a Jamaica college than a campionite. Is that the old man?
I went to Canada.
You went to Canada? The nerve supply of the uterine tube.
To be honest, I'm gonna have to pass this to this.
No, man, I don't want you to pass that because I highlighted that you said.
Vagus?
Huh?
The parts of the vagus?
He says the Vegas. You agree with your campionite friend, Mr. Chuck?
I'm not a campion.
Oh, that's how they're pointing.
Mr. Chuck, where are you in?
Yes.
Where?
Yes.
Yes.
Yes, that's in West
Oh,
George is there.
George.
JC. What? You're from my school.
And he look like a George's man.
Tell me about the nerve supply of the uterine tube. He mentioned Vegas. You agree with him? That Vegas cranial nerve.
I think the video tutor is Vegas.
No.
Well, it's supplied by the Vegas, and then there's a next supply.
Yeah.
Yes,
Help him out.
pelvic.
Pelvic parasympathetic. So that's the dual nerve supply. It's usually half and half, you know? The lateral half is by the vagus, that nerve, cranial nerve going down here. You follow? Whereas the other half is by the parasympathetic S2, 3, and 4. It is said that the arteries have like 2/3, but I don't think that's too relevant, you know? And I never think that the vagus is too relevant, but they are in the exam. This vagus to the uterine tube. Huh?
Which exam is that?
Yes. Now, the tube histology is very important. Mr. Gardner, make sure you come tonight, this afternoon.
Tonight, yes.
Tonight, 8 o'clock.
Yes.
Because the normal lining of this fallopian tube is by, sorry? Mr. Gardner mentioned it at the last.
Yeah. What type of epithelium we associate with the ladies, the women?
Female reproductive.
Female is what type of epithelium? Crystal, female is what type of epithelium? We set it up there. We're young people, right? I set it up there. Females are this type of epithelium, males are this type. Male is what type of epithelium? Pseudostratified columnar with stericilium. Females are? No, never. Females are what?
It's now on the other end, the vagina is stratified.
Columnar ciliated. Columnar.
Yes, so make sure because this is going to be negative.
Man, you have to know that. Urinary transitional.
Yes, ma'am.
Yeah, we know that's basic.
So you have these columnar ciliated cells
Ciliated.
in the tube, eh? But when you look at the histology, you'll see some cells that pop in above the level
Yes.
of the ciliated columnar cells in the tube. You understand? That little young lady there in the dark blue and light blue blouse. You touch her from the side. You know her name? I don't know the name. Yes, that's what you're looking at me now. Some cells will be popping above the level of the columnar. So the columnar will be at that level, but some of the cells, the surface will pop above it, above them. And that's always in the exam. What are these cells called? You grew up in the country, don't you? Did you grow up in the country? No. That pity you guys don't grow up in the country, man. Because in the old time days when you grew up in the country, you had to take out your favorite pet, you know, or it was a goat, and carry them to the pasture. Yeah? And you had to drive a little pig
Yes, pigs.
into the ground and tie them on it. And then you leave them alone, and then you come back later on to fetch them, carry back home. Yeah? So this pig is just like the appearance of the pig that you stick in the ground and tie the animal to. You follow?
Yeah.
That's what they call these cells now, madam. What's her name? You know her name? Sarah, not. The cells are called, they give you the answer already. They are called PEG cells. That's always in the exam. And what is the role of the PEG cells?
Nourishes the lymphatic channels.
Right, for nourishment and developing. And where does fertilization usually occurs? Right, my young Indian girlfriend over there, way at the back over there. Where does fertilization usually occurs? Right, the ampulla. Okay, the ampulla. That's where it usually happens. But unfortunately, we can get ectopic implantation of the fertilized zygote, and that sometimes gives rise to emergency, a ruptured ectopic pregnancy gestation with much bleeding. Patient may or may not be in shock. And sometimes they come in extremis, they're almost like they're gone. But operate on them because as soon as you put a clamp on the vessels to the tube, they always tend to wake up. Okay? So don't give up on these ladies when they come in flat out. Okay? So that's the uterine tube. We mentioned the ovarian ligament and the round ligament already, yeah?
Yeah.
Now,
Rough going, Patrick.
yes,
Air Canada plane crash.
where?
LaGuardia Airport
That's in
in
Canada.
New York.
New York.
Why? Because of
Where?
the TSA agent, the staff. Congress won't pass the money to get them paid, so they're walking off the job.
Oh, my
And
goodness.
the pilot got killed, the stewardess got killed,
Passenger.
and a whole pile of them are rushed to the
So I
hospital.
don't have to travel.
No personnel at the airport.
Now, uterine to round ligament, we talk reach round ligament, right? It will have a blood supply. And the blood supply to the to the round ligament premias. What is it again for premias? What is it? You see that paying attention to all that just moves. I mentioned this to a colleague of yours, not in this class, but in the years gone by. And I guess he was a little bit shocked that I would pick him up for chatting and disturbing his neighbor, you know.
Mm-hmm.
And he reported me, you know about the case.
Yeah.
He reported me to the principal, dean and principal, that I'm discriminating him against him. True, I might be discriminating against him for disturbing the class. You agree? So I'm saying the road ligament will have an arterial supply. What is the name of this arterial supply? Huh? Is that fibromuscular tube, you know? You can see near to the uterus. It was rounded, yes? And as Mr. Gardner had shown to you, as it goes more peripherally, you see it becomes more flat, eh? You see it flat here? You're not seeing it. You see it become flat like a ribbon towards the deeper end.
Oh, we're showing us.
Whereas more towards the ovary, I mean the thing there, it is more of a rounded tube, right? As you did see in all of the other specimens, right? Okay, so what is the arterial supply? Huh? Sorry? Right. There's an arterial branch from the uterine artery that goes with it, called Samson's artery. Yeah? Now, sometimes the ladies, the common position for the uterus is anteverted, anteflex, no?
Yes.
And sometimes it does the opposite. It's retroverted, retroflexed.
Yes.
And somehow or the other, in these ladies, they have a problem with infertility, getting pregnant.
Chinese.
Yes, sir?
The Chinese.
They need one GD, people will go to the molecular reason behind this retroflex thing. Anyway, one of the surgeries they will do is to convert the retroversion into anteversion. Eh? And what they do is make bilateral inguinal hernia incisions through heels when you know the scar. And then they take out that round ligament there and pull both of them. Yeah, shorten them and pull. And by pulling them anteriorly, you can see here, you know, flip over retroverted uterus to become anteverted to improve the chance of fertility pregnancy. Eh?
Anteverted and anteflex.
Right, anteverted and anteflex. You understand? So they call that plication of the round ligament. Okay?
You follow that, Christian?
Yes.
So they have to pull. So the uterus is flopped back on what? What would the uterus be flopped back on?
The bladder.
When it's retroverted, what is it flopped back on?
Rectum.
Right. So they have to know.
Flip it up, all the
Pull
way.
it.
So when they're plicating and putting the sutures, this is where they can damage Samson's artery. And Samson's artery was described by an American gynecologist named Samson. But it's like the proverbial Samson in the Bible. You've seen pictures of he was up the pillars after Delilah found the secret of his hair. That's why Gardner doesn't like the truth. He has a strength there. Anyway, she found it out, and when he found out that she found it out, he decided to get his revenge on them and push the two columns and the whole building collapsed, and everybody died. The story of Samson and the life. So it's easy to remember that story of Samson. Samson's archery. Yeah. So we moving down further into what? The uterus,
Uterus,
now.
no. About 30 minutes.
Good. The uterus develops how, madam? It's not hard. My colleague over there, your colleague over there told you how the tube develops. How the uterus develops now. The tubes develop from what? What's her name? About a nice blouse in short.
Mm-hmm.
Huh?
Her name is Gabriel.
Say that again?
Gabriel.
Gabrielle. Her name is
Your name is Ebony? Okay, how could I forget that? I never ever did know it, that's why I don't remember it. Ebony. Ebony and Ivory lived in harmony. You know that one, Ebony? You never heard about Ebony and Ivory yet? Huh? Side by side on my keyboard. You and me. Huh. Or say Gardner and you. You're Ebony and he's Ivory.
Correct. You're madness.
Okay.
Yeah, man, the period these and different ducts come in and join together, huh?
Yes.
And the fusion results in the formation of the uterus and upper vagina, two-thirds upper vagina, you understand? But sometimes you might have an incomplete fusion with a somewhat development of the uterus. So you have two uterus, but on each uterus now only have one tube on it. But you have two uterine cavities. What they call that scenario.
It's weird.
We can show that in the embryology diagram.
What?
Oh, doctor, that
It's weird.
Thomas will definitely show you those things in the exam. He loves the answer.
What you call this? Two uterus, but only one tube to each. You understand me?
I know this.
Enjoy. What you call it? Uterine. You have, what's the word for two? It's either bi or. Yeah, the D word is di. Right. Right, didelphys. Uterus didelphys. Yeah, so you can get two uteri. And there's a story of one child was born black and one born white.
Yeah, I remember that.
From a story. I never heard about two vaginas yet, George.
Yeah, man.
You have?
So the septum can go right down
Go all the way
through,
down.
and you can have
A double vagina.
yeah, two. Some women, rare though, they have two vaginas.
Don't go into that anymore. Okay. Now, the uterus, as I showed you, right, dreamy eyes, the uterus, as I showed you, is covered on its front, going over the fundus, and posteriorly by peritoneum. Posteriorly, the peritoneum is reflected onto what in the female?
Oh, wait, it's reflected onto the back. It's reflected onto the back. That's the form of puncture.
Its reflection is called the Portia Douglas, but what is it reflected onto? Eh? Rather posteriorly. The rectum. Which piece of the rectum? Which part of the rectum? Mr. Gardner, you didn't go through his lecture, I don't remember these things. He told you that the rectum is divided into three parts.
You can use this, you know.
He told you what you can don't come to the lectures, so when you push come to shove, you don't remember. You do, I can't vouch for you. For the last lecture, there were 15 people here.
How many?
Grand total of 51 faculty. Yeah. Which piece of the rectum now?
Middle third.
Middle third. And anteriorly, it's reflected anteriorly on what? Onto what? Creamy eyes. And it forms what? Pouch now. The rectum can be here somewhere. Reflected from the uterus onto the bladder. So it must be uterocycle. Nothing too hard there.
The front.
Yeah.
You understand? Nothing hard there. No. Mr. Gardner loved to ask you.
Don't
The
ask.
pouch of Douglas now. In relation to the uterus.
Oh my God.
What level does the lowest part, most dependent part of the pouch of Douglas is related to?
External us.
And the other one, the uterine cycle to the,
External.
two of them can be related.
No, the other is internal.
All right, I hear you. And this shows it. You can show me
Brits, you can zoom in on it.
the white colored things here is the pouches, right? So the most dependent part of the posterior and Portia Douglas is related to the right? Whereas the other one, uterovesical, is related to the so don't forget that. Yeah? Good. So we have the uterus now. So you know the peritoneal relationships. And the peritoneum, as it continues over the uterus, the peritoneum, it is reflected laterally onto the side wall of the pelvis and gives rise to the broad ligament of the uterus. Yeah? And within that broad ligament, we mentioned a number of ligamentous portion, the mesosalpinx, the mesovarium, yes? And at the base of the broad ligament running from the side wall of the pelvis into the uterus is the another ligament now.
Is it an
Uterus
I didn't mention round ligament, but round ligament is there. The one at the base of the uterus running from the lateral side wall of the pelvis.
Uterus
From the side wall of the pelvis. Right, the transverse cervical, also called McEnroth ligament, or that's another name, transverse ligament. There's several names, and you should be familiar with it.
That's the name I remember.
And running in this running in this transverse McEnroth ligament is what important structure, which we have shown in the uterine artery. Yeah. Now, from the posterior lateral aspect, you're not Janelle.
Yeah.
You are Janelle. You're mentioning another ligament, the uterosacral ligament. As I see me telling you, running from the sacrum to the uterus. Which pieces are the sacrum? It's the sacral promontory now? Yeah.
Yes.
It's runs in. Yeah. Uterosacral ligament. And what usually running in this uterosacral ligament? Important in the transverse ligament was the uterine artery. Eh? No man, the venology, the arteries. So something else. If it's not the artery and the vein, it must be. Sorry? The nerves. Yeah, and if you're gonna work in America, they'll call the cardinal ligament, the McEnroth ligament, the vascular leash. You know when you're riding a horse and stirrup, yes.
The vascular leash.
The vascular leash, and the posterior uterosacral one, the neural leash, eh? So the nerves will come in. But the nerves to the uterus, which are very important, you know, will approach the uterus not only by the neural leash, but with the blood vessels that are coming in. Yeah, like the uterine artery, yeah?
Yes.
So the uterine artery, when it reaches the uterus, now, what happened to it? Having crossed over the urethra. The uterine artery, when it reaches the uterus, the sides of the uterus, what happened to it? It divides, right?
Yes, divides.
A part going up and a part going down, don't it?
Yes.
Because the uterus is 3 inches long. 1, 2, 3. Yeah? 7.5 centimeters. So the upper part and the lower part, eh? And the upper part will go towards the tube and part taking the supply there, won't it? The lower one will augment the vaginal artery supply. Vaginal artery also comes from the internal iliac as well. Eh? But those that are going now to the uterus proper, from these ascending and descending branches, what happened to them when they approach the uterus? Sorry? Before that. They're going to divide, anterior and posterior branches.
Yes.
And they arch to the midline and meet each other. What you call those arch narrow. In the kidney, what you call those arch narrow. Right, the segmental artery goes up and then like that, the arcuate arteries. So these are the arcuate arteries, huh? and they penetrate the muscle cord, which is a myometrium. And from myometrium, you get the radial and the straighter arteries, helicine arteries. And there's one called the helicine arteries, right, Anton? I know you're looking tired, you need to drink more Blue Mountain coffee like this, like that.
Improving drink them today, that's why I'm tired.
Yes. What are the spiral arteries? So you must come this evening in. I expect to see this class and more. Sorry? The spiral arteries, as the name indicate, they're in the form of a spiral, like a corkscrew. You know the wine, when you drink the wine, Anton, the corkscrew that you push in and then you put an extract, drink your
I
wine.
know like the non-alcoholic.
So that's important because we move from the myometrium in the endometrium.
From my
Right, Julia, is what are the names of the endometrium? You see, anytime you don't look at it, you look at it. Hey, you girls must know about yourself now. Right. So basically, the endometrium has two layers. A basal layer called stratum basale, and a functional layer called stratum functionale. Right? So understand that. The stratum functionale is function, you know, is a part in the reproductive and menstruation thing. It has two layers. What are the two layers now? The stratum functionale.
Compactum.
Huh? Right.
Yeah.
So that's nice and easy to remember. Joel,
Yeah.
because
Yes, Joel, remember that.
where's my BSc? She's the one in the BSc, you know, so? Is she? The biochemist?
She's not here.
She's not here today. She was always there. You know, there's a biochemistry graduate here.
Yeah, but I work with Paul and Davio.
Not here today. Early.
And it's nice and easy because they have their BSc.
With Paul and Davio,
Well,
please.
I don't have my list.
Yes?
With Paul and Davio today.
They came last week
Studying
briefly.
under the moonlight.
Paul came briefly. Anyway, so it's nice and easy to remember BSc because some of you colleagues are doing their
That
BSc,
is-
that's all. Bachelor of Sciences, that's all, BSc.
Yes.
Stratum basale, spongiosum, and compactor.
Amen.
And it's the compactor, it's the functional layers, that is the spongiosum and the
Compact.
compactor that are shed during their menstrual period. And the spiral arteries are supplying them, and they are coiled, highly coiled. Yes, and when they lose their the progesterone, they go into constriction so that you don't get excessive blood loss.
Yeah.
So that is important to follow that.
Yes.
Now the cervix, how long is the cervix?
I'll go for centimeters.
7 centimeters. Come on, as a whole, some
7
centimeters.
centimeters.
That's not 7 centimeters, is that roughly each phalanx is a centimeter on your finger. You can measure it, roughly. Some might be more, some might
7
be.
centimeters. Where are we going to keep that space down? In the trunk of the car? Yeah, man.
All right, if you say 2.5 centimeters, is already the extended.
In the trunk of the car.
Right. So it's not very long. And the cervix has two portions, not so? What are the two portions? You,
No, you have an info.
the portion. No, that's the opening. The osses are the opening. The mouth, the entrance.
Like the end.
So the cervix is divided into two portions. What are the two portions?
Endo and ectocervix.
You could call it that, endo or ecto, but what other better terminology? Portia, portia, and portia, you know, portia, T-I-O.
Portia seems similar.
Portia vaginalis.
Ah.
portion within the vagina, and the portion
Portion
supravaginalis, the portion of the vagina.
Oh, I remember Dr. Francis.
So you know the cervix pushes down into the, or rather not pushes, it protrudes into the vagina. So that's the portion vaginalis. And in you girls, what is the appearance of the external os? Eh? In you girls, the appearance of the external os. Yes, I expect most of you to be.
Because we don't have any children.
Not yet.
Not planning this.
It's usually a little rounded thing, a rounded aperture. And what is its consistency? What it feels like?
Tough.
Hard, right? The knuckles. When you have prostate cancer, you know, you palpate it, feel like your knuckles. And when you have benign prostatic hyperplasia, you feel like the first dorsal interosseous.
P, can I demonstrate something to them?
Yeah, man, sure.
Just for a minute. Breathe it in. Just move it on just a little bit. All right. So, Brits, you can come down on this heart right here. Here. Okay.
Right.
Right now, more.
What that look like to you?
To you, that's maximum.
Yeah.
Okay. So this is the cervix of a nulliparous female.
Yes.
Is it rounded?
So it's rounded,
And the consistencies?
and the little cervical canal is the external osseous circular. Right. So this is a portio vaginalis. So around here, these are the fornices. Okay. So this one just feels. Look here. Watch here. Like the tip of your nose. So feel the tip of your nose, Crystal. That's how the cervix
Yeah,
feels,
you
right?
nulliparous.
Right, and a nulliparous female, it's like the tip of the nose, okay? So watch here. So this is a female now. I think she was about in her 40s, 30s, 40s. But she never had any children, okay? Nulliparous, okay? Then now, this lady I told you, she was in her 30s, but she had had 1 or 2 children.
Okay,
So
let's
look at
see.
the difference between this, you're right here, and then look at this. Right here. Right,
Oh my
right.
God.
So this is a normal, so a female who has had a couple
Child.
children, 2 or 3 children, that's how her cervix is going to look. Okay? Right. No. The cervix is a very important story, you know. The cervix, remember, is like a guard. Okay, guards the what is happening above. Okay, the uterus, yeah. So the cervical, and then now the cervix now has what? Just like lips. See the lips? So it goes from the tip of the nose, and then in a multiparous, when the ONGP person observes, it's like lips. Okay, and then you can see now the fornices going around. See the fornices, how large the fornices. This here, for example, now this is a posterior fornix. Okay, so as you can see, the cervix literally herniates into the anterior wall of the vagina. The cervix literally herniates into the anterior wall of the vagina, and that portion that is there, that is herniated, this is the portio vaginalis. Now, if you look here, just for fun, you see that the color changes. See if you see there's a distinct color change right here. So this is the area now, very important that they're going to do now a pap smear. So this is where we're getting the change now from what type of epithelium. Out here, what type of epithelium? Stratified squamous to columnar, ciliated columnar. So we get the metaplasia. Is that in, Patrick? Right here. Okay, so very, very common for you when the female comes in. You're a GP, you know. You're a GP, okay? You just very quickly, your female patient is there. You have to ask her, so, and you quickly just do a pap smear on her. Which has a little thing that looks like a little small, looks like a little minute, like a microscopic, nearly little what? Wash brush, you know? And they just go like that and just twirl it like that, and then come out and then put it on the slide and send the slide off to the cytologist, right? So there you can see this is a cervix here of a nulliparous, okay, right there, and then one form of of
Let's
contraception
see.
will be, sometimes they will put a diaphragm over here. So they will install the diaphragm right over
So
here.
it prevents this.
Okay? Or they will may put up an IUD. But that is what, this is a female here, maybe in her 30s or so, with never had a child. One that is there. And in fact, if I showed you around and her, she went at the point of death, you know, she was actually ovulating. So if I were to examine and show you, you'll see the little thing just kind of just breaking the surface. I can show it to you, you know,
Oh my
where
God.
where she was just about ovulating at the time of her death. Okay?
We don't see.
And then now we see now an elderly lady. Okay? So this cervix that you see, this big structure right here, you have normal healthy cervix. Okay? And then now we see it has atrophy. Okay, so this is in an elderly lady. Maybe she's in her 70s or 80 years old. Okay, so everything has atrophied, and you can see that the vaginal wall has thinned out. Okay, so very interesting when the women get a little older, is that they start to have incontinence in urine, right? So the urine now, because the vagina, the urethra, which we did look at, runs literally in the anterior wall of the vagina. So the vagina now is just kind of shrinking away, all right, to a degree. So then she gets now urinary incontinence. So then what the ONG person is going to do is to give her some cream, like Premarin cream.
Estrogen.
What? Estrogen type of cream to now rejuvenate the vagina, so it doesn't, decline. So you can see that's a normal. And then this cervix, lastly, has to play a very important role. So in coitus, so when the female now gets sexually aroused, right, then this is where this big structure is definitely needed. Why is it needed in coitus?
What?
In coitus. You don't know what coitus is, right?
Why are you laughing at me for not knowing what
Yes, I know. So, you don't know what coitus is?
I know.
My God, you don't know what coitus is?
They know the terminology, but
Sex.
not experience. Not experience.
Right, coitus, okay? And then sometimes the male now may try not to get the female pregnant, so he will withdraw before he ejaculates. And that's called coitus interruptus. Coitus interruptus.
Coitus interruptus.
But then that usually don't work because the man sometimes has what's called a pre-ejaculate. He's not too sure about that one. But anyway, the real function of this has to be a big structure. Why? Because this is where all the mucus production is coming from. So when the female gets sexually aroused and for coitus to occur, the female has to be properly lubricated. Okay, it has to be all moist and lubricated in there. And that's the function of one of the functions of the cervix. And then finally now, when the female gets pregnant, then now what will happen is that cervix now, is that mucus now becomes a plug. And you get a mucus plug that is sealed off. So it's coitus. Very good, very good. All right. Sorry about it. But you see the three cervices and how they are very different.
Yes.
So as I said, you see the shape of the right, the nulliparous, like the tip of your, exactly like the tip of your nose. And then in the female now, when she's had a couple of children, right, multiparous. And then now you can see how, look, even the wall, how robust the wall of the vagina is here, okay? And then you can see now that in age, now look at the vaginal wall. It's becoming very thin, so sometimes the female will have dryness, okay? So they have to later on use like estrogen creams. And a lot of females have to go on what they call HRT, hormone replacement therapy, right? Because when the estrogen levels drop now, then their sexual desire goes down. And a lot of other functions. Estrogen is very important in the hippocampus in learning. So the hippocampus depends on estrogen. So believe it or not, when a woman takes her exam, should be hopefully at the time when our estrogen levels are highest.
What exam?
Right, you're doing an exam, whether you have a second MBA exam, your MBBS or whatever exam. You want to do your exam or you're making a date for your exam. So you want the date to be at the level of when your estrogens are highest. That's where the hippocampus and the memory system is working great. Okay, but as I said, the hormone replacement. A lot of females have to use it. I have some female friends, and I get very frank with you. They just say, oh, they have no desire for A, B, and C. Okay?
As they should.
And because we know what A, B, and C is, right?
Yes.
And then one of them tells you, oh, Mike, I just took the first dose of HRT, hormone replacement, and whoa! You like a woman all over again. Leave it all alone.
You see, the business of medicine has this, everything we do,
Yeah.
there are advantages and disadvantages. They feel good when you get these hormone replacement therapies. But what happens, you're putting them back into the premenopausal phase.
Right.
So the uterus is going to respond to the hormone. And when you stop the estrogen, what they're going to have is bleeding. So when you're in the 50s and 60s and you stop, let's say 45, and then you start to bleed, then you might start to worry, no? Everything revolves in the brain there. You understand?
Yeah.
You're going to worry about
And
bad things like carcinoma, the cervix, or
Right.
the uterus.
And with hormone replacement therapy, remember the breast is very sensitive to estrogen levels, etc. So if the female now has gone through menopause and then she waits for a long time and she's not doing anything about it, then you can't now go and give estrogen therapy down the line because you now will predispose that female very easily to developing cancers. So if they're going to use it, it has to start early. You can't be waiting till the lady is now nearly 70 years old to say, boy, she wants to go on it. Because then they're playing with fire. They will end up with there. So at that time now, they will tend to give them herbal remedies. Like they tend to take ashwagandha and all kind of agarangavithis and lion mane and all kind of stories. You can't give them the real hormone at that time. Right, and lastly too, that the female also is dependent on the testosterone. So you'll find this is a big, so if you go into ONG and you become ONG people now, it's a big new world out there now because of they're putting now the females on androgens too, testosterone. Right, so it's a combination because that's going to give them their libido or their drive.
Nice.
So Priscilla, that's when you get, that's another 50 years though.
Okay, so when you look at the cervical canal, is there any particular features there already? Really a bright guy, you know.
Right.
That's already nothing.
Yes.
What is it when you look at the cervical canal? The cervix we talk and the cervical canal. Any particular features within the cervical canal? Huh?
The vaginal fornices are located laterally.
I'm not hearing too good yet.
The vaginal fornices are located laterally.
No man, in the canal itself, is there anything peculiar about the cervical canal?
Oblique palpated ridges that is going to help you form.
Yeah, so when you cut through it, what does it look like? When you cut through the cerebellum, the sagittal section
Yes.
through the cerebellum, what is the appearance of the cerebellum? Tree, you know? Orbital uterine. So when you do that to the cervix, what happens? They have a similar appearance. The orbital uterine stem and cerebellum. And as just quite rightly, see, they are transversely running folds. Yeah? And these transverse running folds of the posterior wall will interlock with those of the anterior abdominal wall, you follow? And helps to close off the canal to prevent bacteria and other things going out where they should be, not be going the further. So that's the significance of it.
Yes.
Uterine zone. Why we use uterine zone? So it's fully.
No, to remove. This instrument, Mr. Gardner, is just about every instrument. I'm not sure if he's not doing a little thing
What is that?
back street here. This is called a uterine sound, a valsalon. Forget the name for the moment.
Uterine zone.
Uterine sound. And what this does is like the sonar of this ultrasound.
Right.
Send off a signal, the ultrasound, and when it reaches a point, the base or wherever it is, it's reflected back. That's how ultrasound works, eh? So, sometimes, not sometimes, a lot of times, the ladies have an incomplete abortion.
Right. Just
Yeah.
spontaneously.
Spontaneously. Nothing
Yeah.
illegal or something. It just happens.
Commonly,
And
it commonly happens, and a lot of the babies when they develop, they spontaneously abort. So the female has to be very careful when she gets pregnant and cool it. You know?
Many reasons we won't go into that at this point.
Right.
So what happened? They just keep bleeding and bleeding because products are still retained, incompletely removed the body. So just bleed and bleed and it can get infected. So you, the young doctors now, when they do pass through ONG, you'll have to what they call dilatation and curettage, DNC,
DNC.
of the uterus. But since we're in anatomy, I hope most of you are from mothers and experience the joy of joy of childbirth.
I never heard of one.
Yeah, man, the joy of childbirth.
Never, I don't know what you're talking about.
So the pain now, the labor pain comes from two sources, the uterine body itself. Yes?
Sure.
Or it can come from the dilatation of the cervix. You see how that little another part of the cervix is tiny little hole. And now it's going to be dilated for the baby to come through. That is really the real pain, isn't it?
Ask Christian about how wide will it dilate and
Not
for the
that.
baby to come. 10. There you go. 10.
You understand me? You understand? So, the pain now from the body of uterus and that of the cervix is going to be transmitted through what? What did Dr. Francis said. I think it's important, for you to understand. Because some of you girls, for instance, may be having dysmenorrhea, painful periods.
Yes.
A lot of you young girls have.
So Christian, why do you think the ladies have dysmenorrhea? The young ladies have pain in passing this there. Why? Because of this. The canal is very,
The
very
canal is
tiny.
very, the opening is very
A
narrow.
lot of pain.
So the clots are the breakdown products of the stratum functionale has to be expelled. So you have to contract.
Maybe say once you get pregnant.
But after pregnancy, and that's the joy of pregnancy, no more dismay.
Because you move from this tiny little canal to this.
This big
Right,
old.
so after pregnancy, all of the those pains are all gone.
You understand that? Anyway, this theoretically, the body pain, uterine body pain, with the recontracted muscles now, is coming from, or rather going up through the, which is the sympathetic nerves. You understand me? The sympathetic nervous system, where the dilatation of the cervix is said to be coming from. So on the sympathetic and the other, the pain is going up by a bit. Not if not sympathetic, what else? Parasympathetic, which nerve? The pelvic spine nerve, S2, 3, and 4. So you understand why you girls are experiencing different things. And one of the good things that says, get pregnant, girls.
No, thank you.
Or
Not cherry.
you can get the dilatation of the cervix done, as in a DNC. You have to dilate the cervix,
Let's take the one.
and that is what is that.
And then just to point the instrument here, just for interesting, you have to know the depth of that you can, when you're doing the curettage, your clean, you have to know how far you can go in. So the ONG person has to use this instrument, he called a uterine sound, So it passes the uterine zone. So he knows the depth. No, Christian, he has to know, because you can't just go cleaning out, because you will end up cleaning out right through the cervix, the wall of the
fundus.
uterus.
Through the
Yeah,
fundus.
through the fundus of the uterus. So you have to know, he has to know how far he can pass his instrument to be clearing it out. You get what I mean? A uterine zone. Yeah.
So that
And you will use it one day on a patient.
Oh,
Yeah, yeah.
yeah, all you have to do.
All of you have to do it.
So you learn to
And
sprinkle.
see, yeah. Dr. Len said it when you was in medical school days, on a Saturday morning, Patrick, you said on a Saturday morning,
Every morning.
every morning.
do you give them anesthesia while you're doing it?
Pardon?
Yes.
Oh,
Yes.
I worry for the patient.
All right, so 2 o'clock, histology.
All right, hope you enjoyed the session. But here's
Right.
we continue next.
Yeah.
Here's another session.